Well, hi, everybody. Welcome to another Shop Talk. Today we have Dr. Joe Bialosky, and he'll be talking about his rather famous paper titled Unraveling the Mechanisms of Manual Therapy, Modeling an Approach. And this paper was published in 2018 in JUSPT. Joel, thank you for being here. And do you mind telling our listeners a little bit about yourself, your research interests, and your current role?
Yeah, sure, Chad, and thanks for having me for this as well. Yeah, briefly, my background is as a physical therapist. I got a bachelor's degree in 1990 from Ithaca College when you could get a bachelor's degree. I got an advanced master's degree in 1998 in musculoskeletal physical therapy. And so for the first 14 years of my career, mostly worked in outpatient orthopedics. I was very fortunate to work at the University of Pittsburgh system as a clinician and kind of grew up there clinically as the treat-based classification was being developed and as manual therapy was an important part of that classification system. So my clinical career, I valued manual therapy and practiced it to a point. I guess I would have considered myself a manual therapist during that part of my career. An opportunity just fell into my lap in 2004 to come to the University of Florida and start working on my PhD. And that's where I transitioned from the clinic to more research. Very fortunate that when I came down here, the person I came down to study under, who was Steve George, had similar research interests to my own, which was pain and manual therapy. And so that kind of got the ball rolling on this whole manual therapy mechanistic approach to manual therapy, if you will, kind of starting to try to get a better feeling for not just if manual therapy was effective, but why it might be effective. And that's kind of been where my career has gone, particularly interested in the contextual mechanisms behind manual therapy. So placebo mechanisms, for lack of a better word, and then also some of the changes that occur in pain sensitivity in response to manual therapy too. I'm currently on faculty at the University of Florida. I teach primarily in the musculoskeletal courses here, and I'm also part of a collaboration we have with Brooks Rehabilitation in Jacksonville. We have a research collaboration, so part of my job is working through that as well.
Well, thanks, Joe. I appreciate your strong clinical background. I want to mention to the listeners, too, that you're one of the co-authors of the Mechanisms of Manual Therapy Interventions. This is on sale with the Academy of Orthopedic Physical Therapy. It's a great monograph. I purchased it myself, and it really, I think, it's probably the go-to place to get an understanding of mechanisms of manual therapy. Joe, your paper that we're going to talk about is actually an update from a 2009 paper, which was actually really good. Why did you decide to update it, and what are the biggest differences between the two papers?
Yeah, so the reason behind the update was just that a lot had been published since the original paper. We had grown somewhat in our thoughts and understanding as well, and it just seemed like it was a good time for it. We were giving some presentations, and as we were working on those presentations, started to think, there's some subtle differences that could be accounted for in an update to the model. And after 9 years, we figured it was time. The biggest differences to the model, one is probably accounting for the clinician. So the original model was very patient specific as far as what could be happening within the patient. The revision stepped back a little bit and thought about the clinician and what particular qualities of the clinician or beliefs of the clinician may also play a role in why patients did or did not respond to manual therapy. The other part that we expanded on somewhat too was the outcomes. The original model was very specific to pain. So it was why does manual therapy work for the outcome of pain? And a lot of thought and discussion went into that with the consideration. Initially with the original paper, we really thought that it would be too broad to try to make it account for other outcomes. We still aren't totally convinced that we're not, the revised version of the model doesn't try to take on too much, but we thought that it was better to kind of account for other domains besides just the sensory aspect of pain within the model. And personally, I think that it can do that.
So you mentioned the term contextual a bit ago, and you said accounting for the clinician. So are you talking about accounting for the clinician's role in the contextual effects, or the expertise in application of the clinician, or both?
And I would say probably both. You know, we initially, the initial model very much accounted for specific to the patient, their beliefs as far as preferences, expectations, and that was considered to be a supraspinally mediated neurophysiological response to manual therapy or effective manual therapy. In this one, we think about the clinician and how their beliefs, their preferences, their expectations can potentially influence how a patient responds to it, as well as their training, their experience, and in those aspects as well. So yeah, I think all of that kind of factors in.
So I know I used your model in a U24 grant that we just received through NIH, and your model has been cited a lot. Are you surprised at how positively it's been received?
Yeah, quite honestly, it always is a little bit of a surprise. I think it just came at a good time. You know, I think two things. You know, number one, you know, I was the first author on it. My name goes on it, but when you look at the people involved in it, there's some big hitters. And the original model, we were very fortunate to have access here at the University of Florida to pain researchers that are very well published in the field. These are not manual therapists or not physical therapists, but these were researchers from other backgrounds that are on that original, Don Price, Mike Robinson, on that original manuscript, and provided really great insight to it. I don't think it was anything that others weren't talking about or thinking about, or even doing individual studies to look at different components of it. But I think it just came at a good time while there was a shift in manual therapy. And this is just when you are publishing something, when you do an individual study, when you apply for a grant, this is just an easy resource to put in, or an easy reference to include in there. And I think it encompasses the overall feelings pretty well.
So knowing some of those co-authors, which are very talented, I would love, I mean, how did you come to a consensus with that much talent in the room, that so many different, you know, discussions from accomplished individuals? Was it an easy consensus, or, I mean, describe that to me.
Yeah, so for the original manuscript, I was a PhD student, Chad, and so the consensus was what the more senior individuals told me. You know, I would present ideas, try to interpret things, and then they would get their hands in it. So the original version from that 2009 paper to what actually got published was quite different by the time it got there. And what I've always found interesting is in talking to Steve George, Mark Bishop, to Mike Robinson, and Don Price as we were developing that, when it all came to the end, when you look at it, I mean, it really just describes pain processing. It's not necessarily specific to manual therapy. It's not earth-shattering. But I think because of the traditional way we think of manual therapy, you know, for pain research, like, well, so what? You know, this is something we know for a long time. But I think in the thought process with manual therapy and where it had come from and was going, it was considered somewhat novel. For the follow-up, the revision of it, you know, we're very fortunate that those are some of my really good friends. You know, these are all people that I was fortunate to work with and consider them not just coworkers, but quite honestly, very, very good friends. We all, you know, Steve, George, Mark Bishop were at the University of Florida, and that's why the rest of the co-authors on that came down here. You know, we came down to study with them and learn from them, and so the environment was just amazing for a number of years while everybody was going through the program and working together, and then even starting, you know, our own independent careers and branching off from there. So no, it was really too easy to, you know, we had a lot of discussions, we got a lot of pushback, but ultimately probably a lot easier than it should have been.
Well, before we finish up, and we've got a good bit to go yet, but I'm going to ask you to summarize the mechanism model. But one of the things that you had written in the paper that really resonated with me is you said a single well-defined mechanism of a manual therapy intervention is unlikely, and resulting outcomes are probably related to varying inherent elements and contextual factors. Can you elaborate on that?
Yeah, and this is so one of the first things that I was really interested in when I came down for my PhD was placebo, and how do you develop a placebo for manual therapy? And if you start thinking about it, if by definition, and we can argue strongly about this definition, but if you're going to go with the traditional definition of placebo as inert, what do you take out of manual therapy? What is the active ingredient that you would need to remove so you would have an inert placebo? Drug studies may be a simpler approach to it because we know what the active ingredient is. And so you take that out and you put starch or sugar, but you give them a pill the same size, shape, and color, and that becomes your placebo. And so, but even with drugs where we know, or we think we know much better what the active ingredient is, the response to drugs is still very influenced by the context. So if you give somebody medication and they know they're receiving it versus if it's hooked up to a hidden infusion and they're not aware, the effect of a very effective drug can be dramatically different. And so for something like what we do with manual therapy, these complex interventions that have the interaction between the patient and the provider that are dependent on the patient's beliefs, the provider's beliefs, certainly one single mechanism is not likely to influence. There may be a primary mechanism, and maybe that's responsible for a lot of the effect that we see, but I would argue that there's probably lots of little aspects that go into that, and probably why the response can be so variable across different patients.
Yeah, I think you described that very well. And by the way, I completely agree with that. And I would argue that it goes well outside of manual therapy too, that's exercise or whatever intervention. And you may not be able to do this, but if you could put a number, like a percentage of 0 to 100 on how much the contextual aspect is responsible for the clinical outcome with manual therapy, would you be able to do that? And what would it be?
Yeah, no, a specific number, no. And so first, I mean, I agree completely with you. And I get, what we published in the field of manual therapy, that's what but I really don't want this to come across as, this is specific to manual therapy in terms of exactly what you're saying. I think you could replace exercise, you could replace any intervention and consider that it's going to be much less effective based on these contextual elements. So I don't think this is specific to manual therapy. And I would argue that probably like anything else, a fair amount of the response when it works, a fair amount of the response, or when it doesn't work, a fair amount of the failure response is due to the context in which it's provided. Does the patient believe in it? Does the patient want it to get it? Is the patient willing to follow through with with what it is? So those type of things. So that's a terrible answer, Chad, but
No,
I would say probably substantial, and I'll leave it. But again, I don't think that's a bad thing either. But I'll leave it at that.
well, I don't think it's a bad thing either. I think it really improves our understanding of our interventions. And I have long accepted that as just part of that's, especially with musculoskeletal interventions. I mean, that's what you deal with. So no, I appreciate you going into that, and obviously you can't put a single number on it because it's different for everybody. But all right, so I think it's time, if you don't mind, and we have a lot of more clinician listeners, is there a way that you can describe your model? And I know it's complex, but is there a way that you can describe it for our listeners?
Yeah, I mean, so the model basically suggests that with any manual therapy intervention, first there's that interaction. There's the interaction between the provider and the patient or the client who's going to be receiving it. there's a mechanical force then that occurs with any manual therapy intervention as well. That can be a thrust, it can be a mobilization, non-thrust type of force, it can be a massage type of force, but there's some type of mechanical force. Traditionally, that's been the focus. When I learned manual therapy, when I was practicing, that was the focus, was that mechanical force, that we had to be able to identify areas that needed that mechanical force and then very specifically apply that mechanical force. What the model suggests is that in response to the mechanical force, there's this cascade of neurophysiological responses, and these can occur either at the peripheral nervous system or at the central nervous system at the level of the spinal cord or the supraspinal structures, and most likely an interaction between the peripheral and central nervous system that then results in the clinical outcomes that we see.
Very nice. These mechanisms and the way you describe it, I like it because it actually is coalesced with the clinical encounter. But as you know, there are a lot of research studies that are preclinical, animal-based, and they purely look at mechanisms. Mechanisms and clinical outcomes are not the same thing. Do you think we'll get to a point where we'll understand the relationship better between what we might find in a knockout mice study to clinical outcomes, or does it take a different type of study?
So the animal study, and that is an inherent difficulty with mechanistic studies with something like manual therapy, is that the animal model, the benefit is that you can directly visualize. You can open the animal up and you can directly visualize what's occurring and quantify what's occurring at these different areas, what's happening peripherally, what's happening within the central nervous system. Obviously, in humans, we lack that ability. That's not possible. And so that is an inherent limitation with doing this in humans, is that you're dependent on these behavioral estimates. You have to depend on what the person's telling you, these behavioral assessments that reflect what could be happening within the model or directly visualized within the animal model. Right now, I mean, I think animal studies are helpful in terms of the, hardcore neurophysiological responses, what's happening, but they don't translate for pain right now. And that's a big problem. And that's not specific to manual therapy. That's specific to any interventions. What works very well in an animal model traditionally has not translated to the human. And probably because we can argue about the definition of pain and pain in an animal versus pain in a human, but ultimately I think it's the complexity of the experience in humans and so many other factors. So I'm not convinced that the animal models are going to, at least in my lifetime, help us an awful lot. What I will say though too is, what you talk about with the mechanistic and studies in humans, and what we've typically focused on with that are these immediate effect studies. What happens immediately in response. I think there's value in that type of study design as a mechanistic study. I don't think that an immediate effect study has any place at all if the interest is in clinical outcomes and justifying an intervention specifically for its clinical effectiveness. But for a mechanistic study, I think the immediate effect studies have some value in terms of suggesting how these interventions may work. But I agree with what you said completely, that right now the issue is the next step is tying that into clinical outcomes. If you see this immediate change in some neurophysiological response, how long does it last? And then is that also a precursor to some type of beneficial outcome for the patient that they're going to care about?
Nicely put. So Joel, in your paper, you also mentioned that your model is applicable for different manual therapy interventions, and you say joint mobilization, manipulation, massage, and neurodynamic interventions. Are you suggesting that these have similar mechanisms, or do you think they have similar, and staying away from clinical outcomes, but having similar mechanisms with the patient?
Yeah, so if we stay away from clinical outcomes, because clinically, as you know, a lot of studies that compare these manual therapy interventions, they don't differ. People get better in response to manual therapy A and manual therapy B. There's within group improvement, but there's not the between group changes. And so what that suggests to me is either natural history regression to the mean is really powerful, or there's common factors across the interventions that may account for why people do improve in response to them. When we first started working on the model for the 2009 publication, initially it was going to be specific to spinal manipulation. That's kind of what all the original versions. But as we started working through it and talking about it, we came to think about, when you look at somebody performing these interventions, very similar to each other in terms of there's a direct contact with the patient, your hands are on, you're moving the joint, things are moving in response. The forces may be different in terms of the speed or the force through the pressure with it. But ultimately, I think when you look at them, there's a lot of overlap between them. So to answer your question, I would expect that the mechanisms that are not contextual based, the ones that are related to something specific within the different manual therapies, probably are different. I would expect there are some differences for that component of the outcome across massage versus neurodynamic versus joint manipulation. But I think the model is broad enough to account for those. So I think the model can be applicable to any type of manual therapy intervention.
Fascinating. Joel, you mentioned common factors. I've heard other people call it shared mechanisms. Can you just give us a couple of sentence overview on what you mean by that?
So something, and I don't like the term non-specific, but if we think about why an intervention works between specific factors, like it's directly related to how much force is applied or how much movement's applied, or contextual factors, meaning it's more related to your interaction with the patient or what the patient's beliefs are, the common factors would be those. So it's not, if we do massage, if we do spinal manipulation, if we do neurodynamic, there's going to be specific mechanical parameters for each of those. But the common factor across those may be that I'm interacting with you, you and I get along well, I'm empathetic to you, you think that I'm a really good therapist and that I can help you. Those are factors that aren't necessarily directly specific to one of those. They may go across those. And so that's the question is how much of our interventions are related to these factors that aren't specific to the direct parameters of what we're doing, but really can encompass multiple interventions.
Yeah, I think it's super fascinating. I know in the psychological literature, it's almost all shared mechanisms, regardless of the approach, they get the same outcome. And I think there's probably a lot of overlap with us. So Joel, 15 years as a clinician, so you probably dream as a clinician still. Does your research really reinforce the therapeutic alliance and patient preferences? And when you interact with someone, you're going to find out, first of all, if you're considering manual therapy, what their past experiences have been and whether they think it's something that's useful. I mean, what are your thoughts on that?
Yeah, I mean, the more I go along, the more important I think that is. When I was trained and when I was first kind of growing up in the clinic, it was all about me and my skills, how specific I could be, how good of an evaluator I could be. It all came down to that. But more and more, I think it's less about that and more about, how I talk to the patient, how I get along with the patient, what the patient, does the patient believe in what I'm going to do? And so I guess you're kind of tricking me into answering your original question on how much I think is related to contextual factors. But I do think that's going to play a big role in it.
Well, it wasn't meant to be a trick, but I appreciate you walking me through.
I see how you did that.
Joe, this is an iconic paper. I mean, it has been cited so much. What makes you most proud about this work?
I mean, again, it's more of a surprise, and that it has taken off like it has. But I mean, honestly, it's really just, for me, it's been just a great experience to be able to work with people like Mike Robinson, Don Price, be published with Steve George, Mark Bishop, and and then to kind of grow up with Roy Coronado, Jason Benechak, Chaz Penza, Corey Simon. So I mean, yeah, wouldn't say proud so much, but happy to have had the opportunity to work with them, and happy that we can all kind of be part of something like this.
Joe, if you were stuck in an elevator in 1 minute with all the fellowship, manual therapy fellowship directors, and somebody asked you about your model, what would be your elevator talk to them?
I mean, I guess the elevator talk is, to me, it's kind of putting on paper and kind of coming through the clinical background, and what I struggled with clinically, and then moving into academics. For me, it's really been liberating in terms of working in a clinician in the traditional approach to manual therapy. It was always about, can I feel something? Can I see? And I never bought into that. I never bought into the minutia of feeling these things, or that explanation completely made sense to me. But that still drove the clinical decision making. Yeah, I had to find something out of place. I had to find something that wasn't moving. To me, it's liberating that maybe that's not necessary, and we can still, that there's other reasons why a patient may benefit from manual therapy, and so accounting for those. It's not necessarily identifying these dysfunctional segments, but maybe it's just, this person hurts, it's not contraindicated, there's some suggestion that this may help with the pain, and so go ahead and do it. For this patient, it's appropriate beyond all the other stuff that we go through.
Joe, besides PubMed, where you publish, where can people find or connect with you outside of your email? Are you on Twitter?
I am on Twitter. Just don't expect to see much coming from me. If you're looking to follow somebody to be informed, and then I love following you, Chad, because I learn a lot from following you. That's not going to happen with me. I am on Twitter. I can't tell you what my Twitter handle is or whatever it's called. But the easiest way, quite honestly, is through email. I'm always in front of the computer, and happy to always enjoy hearing from people and corresponding with people. So yeah, email is typically the best way. But if you want a boring Twitter follow, I am there.
Well, I follow you on Twitter. I appreciate it. Hey, thanks for sharing your work, and thanks for helping us here at CMAT, and we wish you the best of luck, and appreciate all the work you do.
Okay, no, thanks, Chad. Appreciate the invitation.